So good afternoon or good evening, everyone. So I'm Sylvia. I'm the co-founder and the CEO of Mira. So if you have ever joined our previous webinar, you know we're running this series of free webinar for you, and we invite the best doctors from this country, and we talk about specific topics. So this is really to help you to learn more about fertility expertise, and if you have any questions, and we can feel free to comment that under Q&A in the Zoom software. So you can see your box over there under at the bottom of your screen or at the top of your screen. So I will introduce Mira a little bit, but before doing that, we are really happy today. We have got Heather here. So Heather is the director in UCSF for the PCOS Clinic. So you may or may not be aware, this month, September, is actually the PCOS Awareness Month. And today we're gonna discuss about the relationship between age and the PCOS. So Heather will have a fantastic presentation to share with everyone, and then we can open for discussion. So maybe Heather, you can introduce yourself a little bit to our audience.
Sure. Hi, I'm Heather Huddleston. I'm one of the physicians at UCSF. I'm a reproductive endocrinologist, and we have a multidisciplinary clinic at UCSF for women with PCOS, and we do a lot of research in the area of PCOS and fertility, and then just PCOS in general. So yes, I'm really pleased to be here to chat.
Great, thanks, Heather. So Heather has extensive knowledge about PCOS, not only in research, but also in clinic. So I think today we're gonna have a really great discussion and learn a lot from you, Heather.
Okay, do you want me to get started?
So I will talk about a few housekeeping things,
Right.
and then I will let you to share your screen. Great. So I know some audience here, you guys might be Mira users, but in case you're not, so Mira is the really small fertility tracker at home. I have a Mira here, it looks like this. So the way Mira measures your fertility level is by sample your urine hormone. So basically you use the Mira Fertility wand to sample your urine, and then Mira gonna measure your numeric hormone concentration. So that's the biggest differentiation, because we can see your actual hormone concentration down to a number. So that means you can plot your hormone curve, our AI can analyze your individualized pattern. So all these suggestions or hormone interpretations will be specifically to you, will be customized to you, in addition to instead of like we're talking about some like OPK or so on. So they're talking about more like a population average. So and we're really excited to announce that we are launching our new product. So Mira used to be able to only measure one hormone, which is LH hormone. So that is to measure your ovulation. But in addition to that, we are shipping our estrogen plus LH test bonds. So this means you use one test bond, you can test both hormones at the same time. So we're actually shipping that this week. So this is super exciting, because with estrogen, you can measure your entire fertile window and also your entire non-fertile window. And also estrogen is one of the most important female hormones. So that hormone is associated with a lot of diseases and your age and your fertility level. So there are a lot of things you can learn about yourself all from that. So I just want to say everything we're offering here is more for educational and informational purpose. It's not really intended to replace your medical advice or the information you're seeking from the doctor. So and then the way it's gonna go is like Heather gonna do her talk for probably the first half an hour, and then we can answer your questions. So please feel free to type in your questions into the Q&A box in Zoom. So don't send to chat. So once you send to Q&A, and everyone please feel free to upvote the question you like them to be answered first. So then we're gonna take them in order. We're gonna answer the most popular questions first. So please feel free to type in your questions anytime. We're gonna answer after Heather's presentation is done. And everyone, please feel free to upvote the questions you like the most to be answered. And then before we start, we like to take a poll from you guys. So because we like to learn more about the your fertility goal and also your age, because our topic today is about the PCOS versus age. So I already put the poll on your screen. So please feel free to type in your answer or just select your answer. I'm gonna give about 10 seconds here. Okay, I'm gonna give 5 more seconds. Okay, great. Great answer. So you should be able to see the result on the screen. So in our audience today, most people are trying to conceive, 84% are trying to conceive, and also about 53%, more than half, actually our audience are between 35 to 44 years old. Great. So thanks so much to help us to learn more about you guys. So our conversation and knowledge could be more towards your needs. And then without further ado, I will stop share. So Heather, if you want to share your screen, and we can get this started.
Okay. Okay, great. So I'm excited to talk today a little bit about PCOS and about fertility and about age. So this is obviously a lot. There's a big topic. Oh, it's a little echoey. Sylvia, can you mute maybe?
Sure.
Okay. So in terms of our learning objectives, I'm going to talk about age and fertility in general. So sort of not talking about PCOS, but just talking about age of all women in general. What does that mean for fertility? Then we're going to talk a little bit about what we know about PCOS and age. And then we'll talk a little bit about PCOS and fertility, but I will try my best to take age into consideration, although it's unfortunate that many of the studies that are out there just don't really do a great job at addressing age and how that might impact decision making for fertility and PCOS. So this is a slide that was done a long time ago where they looked at a bunch of different populations in the world who had natural fertility, meaning they didn't use any birth control, and they just wanted to see, what kind of fertility rate did you see in these communities? So this is like the Huddleston and other communities like that. And it's showing the age of the wife here, and it's showing that that there is this slowing down of fertility rate that we really see, especially after the age of 35, but really to the point where by 45 it's very, very rare for a child to be born. So this is just sort of the natural state of things. So what we sort of extrapolating some of that data, what we can kind of say is that if your peak fertility is in your 20s, in your early 20s, that we know that it's probably come down about 50% by the time you're sort of getting into your later 30s. So that means that a lot of these statistics where people say your chance of getting pregnant on any given month is about 25% based on young, healthy couples. A lot of that data is based on people in their 20s. And so if as you get older, you cut that down by, let's say, 50%, then that might mean your chance of getting pregnant on any given month might be closer to 12%. So that's sort of shown here. So you can see that with age, if you're in this age of 24, your chance of getting pregnant on a given month is 25%, still not that high. But with each passing age or each passing year, we think that tends to go down. So again, it doesn't mean you're infertile when you're in these older age ranges, but it just means on any given month, the chances are lower because there's going to be sort of inadequacies in these eggs. Now, IVF is another treatment that I'm sure lots of you guys have heard about because it's commonly used for women with infertility. And it also can be very successful and to some degree can assist women who are having trouble conceiving on their own in their later years, but it also isn't really a miracle cure for age either. So this is just national data from IVF clinics, and you can see that the pregnancy rate per cycle still goes down with age, even when you have the most aggressive treatments available. Miscarriage rates also go up. So this is just, again, related to the egg quality. And you can see from these data that it's fairly stable through your 30s, but as we get into the 40s, we have a higher rate of miscarriages. And we think this is primarily due to abnormalities that occur in eggs. So I'm going to talk now about this. So a lot of people are like, okay, we know fertility gets worse when we get older, but it really helps to sort of think about why that is the case. And it's a confusing topic these days. So there's really two things going on. We know that egg quality is declining, and we know that egg quantity is declining. The egg quantity issue is kind of interesting though, because egg quantity does go down with each passing year, but regardless of that, women are still ovulating one egg every month. So the fact that their quantity in their ovary is going down shouldn't necessarily make that much of a difference for natural conception. It's really about the quality of that egg. And so when we talk about natural fertility going down with age, predominantly we think this is really focused on the quality of the eggs and what happens to them as they age. So here we have the quantity picture. So this is looking at follicles that we would see in the ovary with an ultrasound. And so follicles are a little packet of fluid that has an egg in it. So the number of follicles you have is kind of a marker for how many eggs overall you have in your ovary. And so this study showed the sort of natural decline in the number of eggs that we would think are in someone's ovary as they get older. And that's through using this marker of the follicle count. But what I think is probably more relevant for fertility issues has more to do with this issue of quality. So you can see here from this slide that we are looking at the number of embryos, and this is IVF data, but it's IVF embryos that were tested, and we looked at the chromosome status of the embryo. So when we look at the chromosomes of an embryo, what we find is that as women get older, they tend to produce more and more embryos that have an abnormal number of chromosomes. And the reason that happens has to do with the older eggs. The older eggs don't do a good job at separating the chromosomes out. And so now you end up with these embryos with abnormal numbers of chromosomes. So really, when we talk about quality of eggs, which I find to be a very vague term, really what we're talking about is the chromosomes that are in that egg and how they result in an embryo that either has the right number or the abnormal number of chromosomes. So you can see in this slide that as you hit sort of the mid-30s, the percent of embryos that we're producing that have an abnormal number of chromosomes really starts to go up to the point where, again, you're in your mid-40s, and now all of a sudden, almost all of these embryos are abnormal. And just like we showed in that first slide, that's right around the time that we think, for the vast majority of women, like that fertility really is the door is shut at that point. That's sort of the latest. So these are the two issues going on. But again, like I said, when we're talking about monthly fertility, it's really probably more about quality. When we're talking about maybe fertility potential with a IVF cycle where you're trying to produce a lot of eggs, sometimes having a lot of quantity can help you because the more eggs you have, the better chance you have of getting a normal one. Okay, so that's when the quantity piece can be of service to us. And that's one area where in some small ways, I think PCOS women do have a slight advantage. So how does egg quantity decline in PCOS? So first of all, we know that women with PCOS have more eggs visible in their ovary. They have more follicles, and that's really one of the ways that PCOS kind of originally got its name of polycystic ovary syndrome. It's really not cysts. These are just small follicles, small packets of fluid in the ovary that have eggs in them. And we know that when we look at a woman with PCOS, we are likely to see lots and lots of eggs, depending on the age of that woman. But let's say this is someone who's 30. We're going to see a lot of eggs in this ovary. A woman who's 30 who doesn't have PCOS, her ovary might look like this. So she's got some eggs sitting around here in this follicle pattern, but she doesn't have anywhere near as many as this woman with PCOS. So this pattern that we see in PCOS with all of these follicles and all these eggs, in some ways contributes to a lot of the problems that women with PCOS have in terms of androgens being elevated and irregular cycles. But it is in some ways, again, kind of nice to know that you're not necessarily running out of eggs faster than your friends. And if anything, they're going to hang around a little longer. So this is a study that we did, and it's kind of getting at the same question. This is where we measured AMH, which is anti-Müllerian hormone level. This is a marker that's produced by follicles. So the more AMH you have, the more follicles you have generally. And so sometimes, especially if you can't do ultrasounds on everyone, AMH can be a really good marker. And we know that women with PCOS tend to have much higher AMH levels. So here's our overall distribution. You can see that the PCOS women in this study had much higher AMH levels. And then we broke it down by age. And so, you can see that the control women, the AMH is much lower, and it's also kind of going down with age. With the PCOS group, it's actually going down a tiny bit, but not that much. And it's still in this older age range, so much higher than the control women. So this is, again, kind of a marker of the number of eggs sitting in those ovaries. In terms of how things are changing, this is also, an area that could really deserve more study. We did a small longitudinal study to try to look at this. And we had a group of 31 women with PCOS and 266 controls who had done ultrasounds twice over a span of multiple years. So we were able to track how were the ovaries changing over the time. And the short answer is just the rate of loss of follicles was a little higher in PCOS. It was 3 follicles per year compared to 1 follicle per year in the controls. When we mapped it out, actually, it wasn't so much that women with PCOS had a faster rate of change. So the red here is the PCOS and the blue is controls. These lines of change are actually the same because these confidence intervals are overlapping. But what we do see is that women who have a high number of follicles to begin with have a higher rate of change. So it's kind of like if you have a lot of follicles to begin with, you're actually going to lose them faster than someone who has a lower number, whether you have PCOS or not. But suffice it to say that this slight increase in rate of loss is unlikely to lead to women with PCOS sort of catching up to control women in terms of number of follicles, at any time soon, right? Because they're starting off often with 2 or 3 times the number of follicles at least visible on ultrasound as a control woman. So nothing too dramatic in terms of what we would see here, other than what I would, say is just, the expected rates of change for all women is pretty much kind of what we see with PCOS, maybe a little bit more, but that's true of anyone with high numbers of eggs. What do we know about other things that change with PCOS? So, we have also looked at that. And so we know that testosterone actually starts to go down with age. And we know that women with PCOS also start to get more regular cycles with age. So it kind of commensurate with the slow decline of follicles and this slow decline of testosterone. Many women will start to resume more regular cycles in their 30s, especially late 30s and early 40s. And so it's often many of my patients who had no cycles when they were in their 20s are often coming back and telling me that they're getting cycles by the time they're in their mid 30s. We know, however, though, at this time, we also do see an increase in the types of metabolic changes. So often women, even though some of these reproductive things are getting better, they're starting to see more problems with blood pressure, more problems with diabetes. And so that really is, raises the importance of sort of continuing to work on just general health, because we know that especially if someone's contemplating a pregnancy as they get a little older, we want to make sure that that person is in as top condition as possible so that they can have a healthy pregnancy. This is one study where they did try to look at a large group of women with PCOS who did IVF compared to women without PCOS, and tried to see, you know, how much of a help maybe it was to have PCOS in terms of the number of eggs you have as you get older. So, you know, if you look at this slide here, this is the black line is women who have PCOS, and the red is women with tubal factor. And so it's basically showing that women with tubal factor, then overall that number of eggs is starting to go down with age, whereas with women with PCOS, it's kind of, you know, this shows it going up. I think it's more likely it's just stable. And similarly, and this is sort of modeled out, but that there's a more stable live birth rate with PCOS and IVF compared to another diagnosis where you might see a more dramatic change with age, because you're having a higher percentage of these women who really have significantly decreased ovarian reserve and are sort of running out of eggs. And so even though I really emphasize the quality as being the main thing, and you have a lot of quantity as you're getting older, sometimes you can kind of overcome some of those quality issues because you can produce so many eggs that you're just getting more sort of rolls of the dice. So in short, women with PCOS do have increased ovarian reserve. They seem to have more follicles compared to non-PCOS. They appear to lose follicles at a similar rate over time compared to non-PCOS, maybe a little bit faster, but still end up having a good number of follicles as they age. The quality of these eggs, though, likely declines with age. There's really no indication that the quality is changing in a different way than women who don't have PCOS. So all of us are faced with this big challenge in egg quality as we get closer to 40, and certainly by, you know, the early to mid 40s. However, by having that larger number of eggs, maybe sometimes women with PCOS might be a little bit better positioned to overcome it. Okay. And then I thought I'd just spend a few minutes just talking a little bit about this, like backing up and just talking about what we do know about options for fertility for women with PCOS. So recently there was these recommendations from the international guidelines. A group of international people all came together, they came up with these guidelines. They didn't really consider age very much in the guidelines, which I think was a missed opportunity, because I do think age drives so many of these decisions. But they kind of reaffirmed first-line medications like Femara or letrozole for PCOS, Clomid, and then metformin, they said, is less effective than ovulation induction medications, but certainly can be considered, especially as something that you add as an adjunct to the letrozole. Second line being gonadotropins or laparoscopic drilling, and then IVF, certainly something that can be considered after that. So, and this is just showing where these mechanisms of action are. So letrozole and Clomid both block the pituitary gland from seeing estrogen that increases follicle stimulating hormone that drives the development of a follicle and the release of an egg. But down here, like with metformin or weight loss, we can impact the insulin resistance, and that can have positive effects on the ovary as well. This is just showing results from a really big study that was done, that confirmed or showed letrozole to be a little more effective than Clomid, although I find in my practice both, you know, I work with both medications, and sometimes letrozole doesn't work, and then I move to Clomid and it does. So, you know, I think both of these it's nice to have multiple medications we can try. This is from the study on Clomid, where they looked at a live birth prediction kind of mapping, and they wanted to say, like, what are the factors that help you have a better chance of conceiving using Clomid? And I think you could consider also letrozole in here. So if you look at the blue and purple, these are the high pregnancy rates in this study. So purple was greater than 60, the blues are like 40 and 50% chance of success. The oranges and reds are bad. So these are like people who had the groups that had lower pregnancy rates. So where are we seeing a lot of blue? So we're seeing the blues over here, first of all. So this group is women who were trying to conceive for less than a year and a half. So if you took a population of women who've been trying for a long time, already that group had a lower chance. And that's probably because it's selecting for really entrenched problems that are harder to fix. The other thing we see is that the group that got either clomiphene or clomiphene and metformin in this study, those were a little bit better than just the metformin group, where you don't see very many pregnancies. Other positive things were age. So you can see this column here is less than 34, and this column here is greater than 34. So overall, we're seeing higher pregnancy rates in the younger women compared to the older women in this study. And then the final thing was BMI. So they stratified by BMI. And so like, even if we were just to look at this little cluster here, we can see that the women who had the lower BMIs did better than the women who had the higher BMIs. So kind of take home message being overall that, and the other thing actually they looked here was hirsutism score. So having a lower hirsutism score was positive, helped your chances. So, in that way, we're saying like sort of maybe the more mild PCOS. But the big things here, I think, were age, the duration of trying to conceive, BMI. These were all things that were drivers of success for women with PCOS. And then what about lifestyle? So, lifestyle we know can increase ovulations and chance of pregnancy. It can reduce pregnancy complications. It's really important for lifelong health. What do we know about whether it helps with pregnancy? So this study was done a few years ago, where they randomized people to like either a lifestyle intervention or they had to sort of sit there and wait on oral contraceptives, and then or you did both. And then after 4 months, they gave everyone Clomid, and they were curious, did the people who had the lifestyle intervention first, did they do better? First of all, they did show that the people who did the lifestyle intervention did lose some weight compared to those who just were on the OCP or birth control pill. And overall, they did show a live birth rate that was higher in the women who did a lifestyle intervention or combined. This was not statistically significant, but it was very close, especially if you combined the combined group and the oral contraceptive and the lifestyle group. So this is showing your live birth rate over time. And you can see that the group that did the lifestyle first did seem to shoot right up, whereas the people that didn't had that slower rise. So I think it's a plug for taking a few months to, try to see if you can optimize your health, if that's something that is a motivator for you. Here they also looked at, whether just going right ahead and doing the Clomid versus waiting, would that make a difference? And short story here was that it's still worth it to take a few months and work on health and then move to your treatment, compared to people who just got right off the bat, started with their Clomid. You can see the live birth rate was better in the women who took that time to do a little lifestyle first. And then IVF. So I'm not going to go into lots of details, but I will say that, certainly many women with PCOS may end up with IVF. It's not really a reason to do IVF if you have PCOS. Usually there's easier things we can do, but sometimes those things don't work, or sometimes there's other things going on, like maybe male factor. So PCOS women do find themselves with IVF in their future sometimes. And so the big things here is we know it's a little riskier. So there's higher rates of hyperstimulation. And so I'm always looking for all kinds of ways to reduce that risk in my patient, especially using antagonist protocols with an agonist trigger. This is a technique to reduce hyperstimulation. And then these medications can, metformin and convergeline can often be helpful, and then freezing the embryos, not transferring fresh. And that is it. So I wanted to make sure I wrapped up in time so that there was time to get to any questions that we have. But thanks so much, Sylvia, for inviting me to participate in this webinar.
Thank you, Heather. I think that was the great presentation. I learned a lot from you already.
Great.
So thanks for that presentation. Okay, great. So, and also I have seen many questions in the Q&A, so that is great. We have really, engaged audience. And so I will talk a little bit about Mira, how Mira gonna help with PCOS, and then we're gonna start to address those questions. So just trying to share my screen. Okay. So we talked a little bit earlier that, what Mira does. So one thing really interesting about Mira is that we test multiple hormones. So LH hormone was the one we launched last year, and we're shipping estrogen really soon. And then after that, we have FSH hormone and the progesterone and the HCG in the pipeline. So with all these things combined, I think there are many interesting things we can find out about ourselves. So for example, for PCOS, always, we usually have elevated LH level, and the ratio between LH level and the FSH level is one of the indicators to diagnose that we have PCOS. And also it's helpful for us to know if our condition is getting better or so on. So then with Mira, every hormone testing will be quantitative. So that means you're gonna get the actual number for your hormone. So there are many interesting things that can be revealed from those testings. And also very interestingly for progesterone, which we target to launch next year. So this hormone will tell you your ovulation has been confirmed. So if you're trying to conceive or you're trying to even avoid pregnancy, you want to know when ovulation is completely down. So it's very safe to have sex. That's a hormone to look into. And the HCG, so as Heather talked about, when we're getting older, the rate for miscarriage is definitely increasing. So with the HCG testing at home, so you can see, is there any early sign for the for the miscarriage gonna happen? So we can take early actions. So specifically with PCOS, I think it's interesting to understand a little bit about how our hormone works, because our hormones are more like the fundamental driver for many things that's happening in our cycle. So this hormone, the light blue hormone, is our LH hormone. So this hormone increase right before your ovulation. So usually that happens about 12 to 24 hours for most women. So Mira is able to detect the surge, which is the increasing pattern for this hormone. So, and then the ovulation is usually likely to occur right after that. And another hormone, estradiol or estrogen, so that's the hormone we were talking about earlier. So this hormone tend to increase a few days before the LH hormone. And since the sperm, if the sperm has good quality and the woman's mucus has good quality too. So if those happen and the sperm can live inside the woman's body up to 4 to 5 days. So that means your fertile window can be 4 to 5 days before the ovulation and until the day of ovulation itself. And unfortunately, after ovulation, our egg only lives up to 24 hours. So I think up to 24 hours means if you're really healthy, and if you're getting older, the time is probably shorter. So in order to try to conceive successfully, you really want to capture the time early. So, upfront, capture this entire fertile window, so you can have higher chance. Basically, you don't waste any days. And the progesterone, we talked about this a little bit too. So this hormone will increase after your ovulation is done. So that's very interesting because I can confirm ovulation actually happens. For a lot of people with PCOS, we have the LH surge because we have many follicles. Our body is trying to ovulate, but not every time the ovulation will successfully happen. So that means if you really see the progesterone increase, more likely the ovulation actually happened. So that's like a confirmation signal. So that's very important too. So with all this, you can see the key here is that these hormones are relative in their level. So every woman is different, every cycle is different. So some people can have really high baseline, some people can have low peak. So if if we're using the OPK or test with more weak methods, it's just hard to identify sometimes. Is this really happening to me, or is that just based on a population average? So especially with people with PCOS, this pattern tend to not that regular. So many times people have multiple LH hormone surge, or even they have elevated hormone baseline. So that means the contrast between the LH peak and the LH baseline is not that obvious. So it's hard to find. So that's why when using Mira, we can test your actual number and you can see the pattern. We always tell our users that the pattern is much more important than one absolute number, right? Because a number came in, like for example, 20 came in a peak for some people, but came in the baseline for some other people. So it's hard to identify exactly what's happening with your body. But with this pattern, with a long-term trend, you're able to, learn more about your body, and you can see the trend when it's increasing, and then you probably should try to conceive when this trend happen, when the surge start to happen, and to not miss any opportunity. So we also have done some clinical study. I'm not going to go to detail about this, but we tested Mira, and we used a patient sample. We tested by Mira. We also tested by Abbott i2000. So Abbott i2000 is the machine we're using in lab testing. So when you go to draw the blood, and they put your blood sample on this really huge automation machine, and we got very high correlation. That means the accuracy is very high. So then I'm gonna stop share here. I know people have many questions, and I actually have seen many questions about Mira. So maybe I will address some questions about Mira first, and then I will give the rest to Heather so we can have some interesting discussion. Great. So let me see, I'm just going down the list. So Jennifer is asking, will the estrogen stick be sent out to all clients using this? And I just placed order with my new Mira on Tuesday of this week. So the estrogen is a different ones. Okay, so these ones can test both the estrogen and the LH level at the same time. So you can, if you purchase the Mira analyzer already and you didn't purchase the the estrogen test one, estrogen test, the starter kit, you can actually just purchase the Mira test ones together with that. Okay, so that means your current analyzer will work with these new test ones. You will have a choice. You can purchase the LH only test one, or you can purchase the estrogen plus LH test ones. So I will, after Heather take care of those questions, I will put a link into there so you guys can see where to purchase. And as long as your analyzer is relatively new, which means you purchased within this year, and most likely the analyzer will work perfectly with the new estrogen test ones. And if your analyzer is older than that, what we need to do is we need to teach you how to do an upgrade, like a software upgrade, just like updating your Apple Watch. So it should be pretty straightforward, just takes a couple seconds, and then you should be able to use that. Okay. So also I see, so let me see, it's a similar question. So this is an interesting question. So Shamini is asking, I just got my Mira. I have PCOS since many years. I want to know if women have PCOS will ovulate every month. So, and also want to say, if we're ovulating, do we need to test once or twice a day with Mira? So the answer is no. So women with PCOS are unlikely gonna ovulate very regularly every month, but also there is a personal variability. So it really depends on who you are and also your cycle situation. Sometimes you do ovulate, sometimes you don't, but your body may be trying. So when they're trying, you see the LH hormone surge. So we recommend that if you see the LH hormone surge, you have sex if you're trying to conceive, because there is a chance the egg will be released successfully, so you can be fertile at the times you can try to conceive. And when you say positive, or when you say ovulation on Mira, and the app will remind you to test again within 6 hours. This is really to confirm you're ovulating and not miss the opportunity. So I hope that answered your question. And another question about Mira is how does Mira will calculate my next cycle, my fertile window when I first receive that. So when you first receive that, Mira will ask you to enter your last cycle information and your average cycle length. So this will be purely based on calculation. First month calculation will be based on the algorithm. So basically your historical data. And however, when you start to test, and every test you synchronize the data to the Mira app, the app will learn. So it's not like, oh, I'm not going to update until next cycle. It's more like, every testing you are doing, the Mira will get more accurate and will get more personalized to you. So another question from Lisa. So Lisa is asking, just to get my Mira, do I need to use them for the whole entire period? And if you have irregular period, when to find out? So you don't have to test for the entire cycle. I assume you meet the cycle. And most likely the app will tell you like when to test. Okay, so usually you will ask you to test them more often when you're close to the fertile window and much less often when you're away from the fertile window. So if you have irregular period, and you will likely to test more often, so you don't have to exactly follow the testing days, but you want to test them more often than less often. You know what I mean? So the app can learn, the algorithm can learn what's going on with your body. Okay, so let me see, is there any other questions about Mira before we move forward? Okay, I think we're good. If we see any other question, I will try to answer that along the way. All right, so we have some really interesting questions for Heather. So Heather said, Angela is asking, she said all the data we're looking at seems like a little bit dated. Is there anything from the past 5 to 10 years? Maybe there's any new findings, exciting new findings you want to share with our audience?
Well, I think I tried to cite the strongest, largest studies that have been done and the ones that sort of have the most sort of like credibility in the clinical world. So the study that I cited about the sort of exercise intervention, the OWL study, I think was like 2016, 2017, I think that's really the most recent sort of large, really well done study that's been done with PCOS. So I don't think there's anything like new that's fully validated out there. I'm sure there's like things people are trying and things that you might find in the literature, but in terms of good large studies, that's what we have.
Great, thank you. So another question from Esther. So she said, how can a person improve egg quality and egg quantity in their mid-40s?
There, unfortunately, I don't think there's really any way to do either of those things, at least as far as we know right now. So, that's obviously like really like the holy grail, I guess, of fertility is to try to somehow change our egg quality. As far as we can tell right now, it doesn't, there's not, there's a few things that we know that really can impair egg quality, but very few, there's very few of these things. So the two things really are smoking and obesity. So we do think that both of those things can impair egg quality. So other than those two things, if you're working as hard as you can to keep a healthy BMI and you're not smoking, then the rest of it is likely driven by your genes in terms of just sort of general cellular aging. So, and then it's kind of the same for quantity as well. There's not, as far as we know, and I'm sure lots of people would love to see this change someday, but right now we don't have good interventions to sort of somehow change people's egg quantity. That's like a struggle of every IVF clinic right now, obviously, with all of our patients.
Yeah, okay, that's great. So another really popular question, can you share some thoughts about the hypothyroidism and the PCOS?
Well, I mean, I think it certainly is something we see. It goes, we see often that PCOS women may also have some degree of hypothyroidism. And right now we do want to have we generally recommend having a pretty well-controlled thyroid for fertility. So we like to keep the TSH in the sort of, no higher than 2.5 or 3, a little bit of a controversial area. Some people are questioning that, how aggressive we need to be, but I tend to like to see my women be fairly well controlled. And so with PCOS, that's certainly something we see they may struggle with. And so treating with thyroid supplementation to just help people have a TSH more in the sort of below 3 range, I think is advisable.
Thank you. And one girl is interested in that. She said, where can we find the data about LH level during ovulation for women with and without PCOS? So I think her question is more like, where the hormone level should be.
Yeah, I think that I don't know that I've really seen a study that's done that. I think it's a good question. I think what we would assume is that women with PCOS still are going to, like, in order to have a healthy ovulation, that is going to release an egg and support the corpus luteum, which is the part of the ovary that's going to produce progesterone throughout the whole second half of the cycle. In order to have that really solid ovulation and corpus luteum production, you're going to need a very strong LH surge. And so typically we would expect that's going to be, you know, something like 70, 80, 90, 100. It is going to vary a little bit for different women. It's going to, you know, it's a peak. So depending on where you get it, you know, it's hard to know what that actual peak was, but we want to see really solid numbers like that for anybody. I think the difference with PCOS is that women are starting at that higher baseline. And so it can be a little tricky to pick up the surge, especially with like the older technologies, because if they're just telling you positive LH based on a threshold, then women with PCOS are going to be positive in the beginning of the cycle too.
Yeah, exactly. So thanks, Heather, for that point. So that linked to what we talked earlier is that, you know, if you have PCOS, your baseline can be high and you can have multiple peaks. Some peaks might be smaller peaks, and then you really want to know where the level is at instead of just, oh, positive, negative, but because that may not mean positive or negative for you. That means for some population average or for more like a healthy woman.
Mm-hmm.
So I just found another question about Mira here. So this girl is asking, I have PCOS and I have inconsistent cycle, like different days. How does Mira calculate my fertile window because the cycle is inconsistent? So Mira usually calculate your cycle or predict your cycle from the data collected at the you know, in the past. So every data you entered, we will apply, actually the algorithm will apply a weight on that. So we assume, you know, the general assumption is that although you have inconsistent cycle, but there should be, you know, certain range you're in, right? So it shouldn't be like one is 100 days, another one is like 10 days like that. So we will find where this center point or this balance point is roughly at, and then for this cycle days that's or cycle length that's closer to this balance point, they will contribute as a higher weight. And for something that's really, like, for example, you didn't ovulate for 3 months, for 6 months, those super long cycles, those will have a, you know, less weight, so that will affect the algorithm less. So that's how we're calculating. But I highly suggest you that, you know, for if you have PCOS, because it can be kind of random, it will be hard for the algorithm to predict very accurately for something random. So I just recommend you to, you know, test more, especially at your, you know, predicted ovulation window, test more often. And if you see the outreach increase, you probably want to try to conceive, because that can be a chance for ovulation. And obviously, if you see really strong outreach surge, that is most likely the ovulation, so you don't want to miss that opportunity. So another question for Heather. So she said, I often spot 3 to 5 days before my actual period begins. Could this be a sign of PCOS, or is more likely for low progesterone level?
I would say if someone is having cycles monthly, but they are having spotting right before they get their period, that wouldn't necessarily point me in the direction of PCOS. It tells me more maybe that there could be an issue with slightly lower progesterone. Sometimes it can mean there's like a polyp in the uterus, so it could be something also just structural, but often we tend to think, when I hear that history, that would be one of the things on my mind, is there a slightly shorter luteal phase because of slightly lower progesterone in the luteal phase.
Mm-hmm. Got it. So Victoria is asking, so do you recommend freezing for IVF, or do you recommend the fresh cycle IVF?
Well, I think there is a study that seems to suggest there could be some benefit for doing a frozen cycle, you know, transferring embryos from a frozen cycle with PCOS, so not transferring fresh. I often will encourage women to do that, partly because of the increased pregnancy rate, and partly because often this is a group that is at increased risk of hyperstimulation during the cycle. And so it's safer to try to like let all of the hormones calm down and like let everything reset, and then go back to, the more calm preparation that you can have with a frozen cycle and put the embryo in that situation. So I think it's a little bit safer and probably has appears to have a slightly higher pregnancy rate for this population.
Sure, sounds good. And Anna is asking, what is the percentage to conceive? I think she means the percentage or chance to conceive at age 35. Actually, we have seen many questions from the past, and people are asking, oh, is 35 just like a cutoff point, or what's really magically happening at 35?
Nothing's really happening dramatically at 35. It's definitely not a cutoff point. It is always going to be this sort of very gradual reduction in fertility rates over time. We do see a slight acceleration of that decline in the mid 30s. And of course, these are just population averages. So it is probably different for different women. But what you see when you look at these big population studies is that there's like a pretty slow decline in fertility rates up until 35. And then around 35 is when we start to see each year kind of a slightly bigger drop. Mm-hmm. And so then, by the time you're in your early 40s, that's where we're starting to see it become very difficult. So it's kind of like 35 is just your warning flag of saying like, hey, it's going to start getting harder. So the next sort of few years are really a time you want to capitalize on, because once you get into the sort of 41, 42, 43, that's where I see the patients really become very challenged to be successful. So, I think of 35 as a very easy age to help. When I see patients from a fertility standpoint, that's a group that has a very good prognosis, but it's just also a warning sign that you don't want to wait a whole lot longer. You don't want to push yourself into a phase of life where it's actually going to be super challenging, even with treatment.
Sure, understood. So Elizabeth is asking about how can she know she's pregnant? I think this might be a question for a lot of women with PCOS because we're not sure about when ovulation happened. So she said she has been spotting for 2 days, but she tested negative in HCG recently, but she feels like a pregnant. So what's your suggestion about when or how they should test for early pregnancy?
Yeah, I mean, I think it's tricky with PCOS because if your cycles aren't normal, like you don't have that regular sort of warning sign that you're pregnant the way someone who has regular cycles does, that might tip them off that they're pregnant. So, I think that the over-the-counter pregnancy tests are pretty good. I mean, so any test that it can give you a sense of your HCG is, a reasonable thing to do. It is going to be, their cutoffs of these tests are, really should tell you if you're at the point of pregnancy where you would normally be missing your period. So that's like 2 weeks after ovulation. So I think if you do one of those tests and you're negative, then, it's likely that that you're just not pregnant. It could be that you did ovulate and you just haven't gotten your period yet. Sometimes the symptoms of sort of being post-ovulation can be similar to symptoms of pregnancy in terms of bloating and breast tenderness.
Cool. And Anna is asking that, is it common to have low LH for PCOS? So she has been testing with Mira, but she just see a really low hormone number for her.
LH is not one of the diagnostic labs that we do for PCOS. I mean, I like to look at LH levels because I often think it's helpful in me seeing like what type of PCOS someone has, and higher LHs kind of can go along with different features sometimes, but it's not a diagnostic test for PCOS. So there's one of the reasons it's not, and it used to be something people looked at much more often, but the reason we didn't make it a diagnostic criteria is that not all women have elevated LH, but they still may have PCOS. So it's hard to know in this particular case if the LH is very different than what from the Mira is different than what you're seeing in the lab, or if you just are someone who has that slighter lower LH level, even though you have PCOS. And I guess I would just have to look at all of the details to know for sure.
Sure. So another question, very interesting from Jennifer. So she said she got pregnant with IUI when she was at 35, and now she's 39, and she wants to get pregnant without treatment. She's taking metformin every day. Is that possible? Do you recommend that or no?
Well, I think if Jennifer is getting regular cycles, like if she thinks she's ovulating every month, then she's got a shot, you know. So women with PCOS, I don't necessarily even think of it as an infertility diagnosis. I think of it as just an ovulation problem. And so if you're ovulating regularly and you can document that, then you're really, you know, not all that different than any other woman with any other woman who's trying to get pregnant. So you're ovulating and you can try each month, and you know, if the metformin's helping with that, that's great too.
Mm-hmm. Got it. Sounds good. So I think we can take 2 more questions. So one question here. So they're asking about if we have a shorter luteal phase, do you have a lower chance to get pregnant?
Well, it's, you know, one of these things that we sometimes look at, because if the luteal phase is very short, sometimes it's an indication that the ovulation itself, like when you ovulated, and then the ovulation should then help you produce progesterone in the second half. Mm-hmm. So if you've got a short luteal phase, it may mean that the progesterone levels aren't that great. And if the progesterone levels aren't that great, that may mean that the uterine lining's not getting adequately prepared for implantation. So we do think sometimes it can be sort of something we might want to try to fix if we see it. And so often what we'll do is help boost ovulation. Something like Clomid or letrozole is a good way to do that, sort of give a stronger ovulation, and then ideally get that sort of more solid, long luteal phase.
Mm-hmm. Got it. So just one side comment here. So when we're launching the estrogen test ones, like in a couple, actually the estrogen will ship like this week, but in a couple of weeks, we are also going to launch our new Mira app. So just a little secret to share with everyone. So in the new Mira app, you will be able to see your luteal phase and also follicular phase. So you can see the phase list, not just the cycle list, and also you can compare multiple cycle, like all the past history, I think more than 10, you can compare that. So you can see your trend about those phases, cycle phases as well.
That's cool.
Yeah, great. So another question about I think it's actually about Mira. So can I use Mira after having IUD? Was that where did I go? So will the reading change? I think the answer is like, you know, are you while you're having IUD, are you still ovulating? If you're trying to detect ovulating and you're having IUD, you may not be ovulating, right? So if you're not ovulating, so you're not gonna see the hormone change. However, if you want to get rid of IUD, you can test with Mira to see when the cycle and the first ovulation will come back, because first ovulation usually happens before the first period, so you can know that early. Great. So I still see many questions here, which is great. We have so many engaged audience. So for any question about Mira, you guys can reach out to support@miracare.com. They will for sure answer every single question you guys have. So feel free to bother them. And then Heather, if our users have any questions, where can they find you?
Well, I work at UCSF, so, you know, it's, people can try to reach out to me through the clinic and come see me if you're in our area, or, you know, my email is heather.huddleston@ucsf.edu.
Great, thank you so much. And I'd like to share another final good news. So we're giving our attendees today a special promotional code. So if you just enter AGE&PCOS at miracare.com, and if you want to purchase the Mira Fertility Kit or Mira Fertility Plus Kit, so the difference is like a fertility kit is LH testing, and the Fertility Plus Kit is LH plus estrogen testing. So you can get $20 off. So that's 10% off. And since Mira Fertility Plus Kit is on the pre-order still today, so we didn't run any promotion. So this is the first promotion we're running for that. So if you're new to Mira, you want to join, you want to try to test your numerical hormone concentration together with estrogen, this is the first product in the market that you can test your numerical hormone concentration for estrogen at home. So feel free to utilize that code before it expires. It's going to be a limited time offer, and only for our audience today. So before we finish, I'd like to take a final poll. So this poll will be about your feedback to the webinar. Do you think that's helpful, or you want to see anything specific in the future? So please let us know how we're doing, and so this can help us to provide you more meaningful, more helpful, and more great content for free to you. Okay, I'm gonna give 5 more seconds. Please let us know how we did. Great, thanks everyone. I think that's it. So yeah, thanks so much everyone for your time, and I especially like to thank Heather to join us and provide all these really great and beneficial free comments, free suggestions, and answer many questions from our users. Thank you so much, guys, and we will see you next time in your next webinar.
Thank you.
Thank you. Bye.